夹子的徽状是像什么方的看？那塑料这样，我们拿这个最加，所以它这个机制称为叫防呆机制，有没有风险性？
我们是收集资料不够，会觉得都是做好，直接东西回到手机做啊，换成我的 One Day 吗？这个是internal的。
各位现场贵宾以及所有我们业界的先进们，大家好，大家早安！欢迎莅临第3届中华民国临床植牙医学会的年会。那么今天我们非常开心，也非常荣幸能够邀请所有各位贵宾们参加我们本次的年会。那么这一次我们的大会主题是 One Day Implant。那么我们将于今日的年会现场发表最新植牙技术。那么大家也都知道，自古以来，快速、安全、便利、美观的植牙技术，一直就是我们众多医师们所追求的。而国际知名的 mininally 研发团队，在多年3年之后，终于成功研发，并且正式命名为 One Day Implant。那么今天我们的团队也到现场来跟大家见面，所以在这里呢，我们邀请所有的朋友给我们团队一个掌声。Ladies and gentlemen, our Eureka R2 team， 请给他们一个最热情的掌声，好吗？Okay, welcome our Eureka R2 team。那么当然，在本次年会呢，我们也特别邀请到研发团队的成员以及团队召集人，同时也是我们全亚洲最大私人牙医连锁 Mir Dental Hospital 的 CEO Dr. Park。那么他今日呢，将和我们一起来一解 One Day Implant 的奥秘，分享植牙最新的趋势以及科技。所以紧接着下来，我们就要开始今天重要的课程内容。首先，我们要邀请到的第一段主讲者，就是我们亚洲植牙教父，也是我们 mininally 研发团队的召集人，同时也是 Mir Dental Hospital 的 CEO， 来为我们介绍新时代的植体以及植牙技术。So, ladies and gentlemen, let's welcome Dr. Heart from Home， 来给我们的 Dr. Park 一个最热情的掌声。
Thank you, Jennifer, for the nice introduction. And 大家好。好。Thank you, Dr. Cho, and my best friend Christian, and all the participants and staffs for this meeting. I'm very happy to share our recent advances on the one-day implant. Actually, as you know, this is the first presentation on this topic in Taipei, but we are moving forward every minute. So I think we can share some recent advances on this topic. Actually, to do one-day implant, we have to have the full program, actually, from the base to the top. So today we will introduce many fundamental things from implant to the advanced program, softwares and hardwares to make one-day implant possible. So today's schedule is quite tight. Today we have 5 sessions. The first session was started already. So we will introduce the enriched implant system and its long-term prognosis. Slide 8. At the break, for section 2, we will introduce about new gadgets for regenerations. So how to overcome which deficiencies. And we have lunch in the afternoon, session 3. So we will show you how one-day implant can be possible. So the first thing will be live surgeries. 2 live surgeries will be shown. And I will show you one. And Dr. Wang in Taipei will present his own live surgery case. And then after that, Dr. Han will show you the ISQ value change on our specific implant system. And on session 4, Dr. Lin, Dr. Coach Lin, will present about the design, concept, and the stress distribution of the energy system. This is very important, and we have to understand why this is special for one-day implants. And then at the break, Dr. Chung Kim will give a presentation about our new program named R2Gate and DDS program, about the software and how to teach hardware for one-day implants. So let's start. Please. So let's see the video first. This is Eureka R1, and we are moving to Eureka R2 stage.
An event occurred that opened a new beginning in dentistry. Dr. Bronmark of Gothenburg University, Sweden, discovered a phenomenon called osseointegration while studying bones and blood vessels. Dr. Bronmark successfully performed a surgery placing 4 titanium implants, supporting dentures on the edentulous lower jaw of his patient, Mr. Larsen. The Swedish government officially approved Bronmark method, announcing that the procedure would be covered by the National Health Insurance. Finally, the titanium implantation procedure was recognized by the world of dentistry in Toronto Congress in Canada, and began to be actively used from North America.
Since the commercial production of Bronmark implants by Nobel Pharma in Sweden began, many implants of various concepts from many different implant companies have appeared and disappeared. Still today, developments and improvements are being made to produce better dental implants. It was proven that the roughness of the titanium surface greatly affects osseointegration, spurring companies to innovate on surface treatment techniques, such as SLA anodizing, TiO2 blasting, DBS, HA, RBM. In addition, enormous advances in regeneration techniques and materials, diagnostic equipment, and surgical tools have been made. This evolution has led to dental implantation becoming a technique that may be applied to any patient in almost any condition. After a fixture is placed in the alveolar bone, a period of time should elapse before loading, and then the abutment is connected in order to deliver the prosthesis. This has been the standard protocol to date.
Yeah. Implant can be explained as a eureka. Eureka is, I found something. The meaning is, yes, it is. I got one. I got new one. I found something. Implant is really something. During the last 50 years, the survival rate became more than 95%. And the long term, the advances on the regeneration techniques made every case possible with implant treatments. Still, we have some limitations on implant treatments. We have to wait until the implant is with a living bone. So, it's the first obstacles of the one-day implants. Also, still we have some limitations on the regenerations. Even the materials and the techniques improve a lot. So, on the Eureka R2 stage, we want to eliminate all the obstacles, actually. So, the first and the final goal for the Eureka R2 is one-day implant, actually. This project is our agenda of Megagen implants for the next 10 years. In this project, we are going to formulate a system of diagnosis and treatments through the R2G program. And with the cooperation with healthcare system, one-day implant treatment will become more and more popular in daily practice. And also, we are trying to overcome. We're trying to make new systems for the regenerations. It will be CAD/CAM technique also, and we need to put some regeneration proteins on the CAD/CAM bone graft materials. We cannot show all of these today, but just I'd like to introduce the recent advances on the one-day implant concept. So to do one-day implants, it should be precise, very precise. So I will show you the concept of the one-day implant first. It's simply. So we will provide you the surgical stent and the customized abutment and the crown before treatments, before surgery. It's the first time in the world. So you can place implants through the surgical stent. And this is very popular now. Surgical stent concept is not unique. And then you have to place special implants named Enrich. Why this is, I will explain why Enrich implant is so special. need to take measurement. You need to measure the initial stability with the osteometer or ISQ. Some devices, how strongly it was fixated. So it should be more than 70 on the ISQ value. But if you have more than 70 ISQ value, it can be explained as a reliable initial stability. So anyway, will give you more than 70 ISQ value anytime, anywhere in the mouse. So initial stability was increased, or not increased. You can control by yourself. And the more important thing is, unlike other implant systems, showing descent on the ISQ values until third and the fourth week, and going up, and reach implant will show you stable or increased ISQ value always. So this is most important concept on the implant system. So we have to remember this graph. And then, yes, as you see in this graph, in this case, all the implant shows stable, increasing ISQ value. About this, Dr. Han Chang-hoon will give a presentation later. And then, if you had more than 70 or more than 70 ISQ value, you can connect the customized abutments immediately after implant placement, and you can connect crown at the same time. So patients can go out to the office with the crown, stabilized crown, on the implants. There are so many implant systems in the world, more than 300 different kinds. And all the implant system has its own special advantage. But, as you know, these are different from here to there. But we are placing almost the same kind of implant system. We have this. So, during the last 10 years, 11 years, we tried to develop a special implant system for each implant, for each teeth. So, we have this much implant lines. So, for the small teeth, we have to place a skin implants. For the molar, we need the fatty and short implants because of anatomic limitations. It was good, very nice as a concept of Eureka R1, as just implants. But it was not enough for the one-day implants. All our patients want to have crowns immediately after surgery. So we start to think again. As the start of any rich implant system. Okay, so already I presented about the NUH system several times in Taipei. Yes, we can say this is a thinking man's privilege. You have to think a little bit complicated, a little bit difficult to understand the proper way of placement. I will explain later. Yes. What is ideal pictures? You have to understand from here. Not only for the initial stability. Some patients which looks like this. And then, to get more initial stability, taper design is always better. And then, the apical diameter should be narrow as possible. You will see the advantage of the narrow apical diameter later in the afternoon. And the problem occurs in this area. Usually, our patients has a very limited crestal width. Our common implant looks like this. The widest area is always at the top, at the platform. But patients has the narrowest portion at the top. So it has mismatching. So we have to preserve this area for the long-term maintenance and to minimize the complications like gingivilization or bone destruction. This area should be preserved. So I will explain about this later again. And yes, as you imagine, your implants. So it will be like this. Taipei design is very nice to get initial stability from this area, but later, after placement of final restorations, you will start to have a bone loss because of limited amount of crestal ridge. So, this is same loss. So currently, the design is not good. We just draw with a pencil the ideal design of the implants. The thread design should be changed also. It should be deep and knife-threaded. The advantage of this thread design will be explained by many speakers today. Ideal abutments, this is not the actual topic today, but anyway, the maintenance and the long-term prognosis will start with this area. So, connection with implants, connection abutments with implants is very important. It should have anatomic curvature, and to make the procedure easy, there are many variety of abutment systems. And the connection is also very important. I will explain it later. And if we have a very strong connections, we don't need to have a strong abutment screw. So we minimize the size of the screw. Abutment screw need to just introduce the abutment into the fixtures. When it was tightened, we need to have screws actually. The first and the most important character of any system is on the knife edge, knife thread. It looks like round, but on the wider diameters, more than 5 millimeters, you will see it's like a real knife. With this change, we can increase the cutting efficiency during insertion, and we can get excellent initial stabilization. And after integrations, this wide knife thread can withstand the occlusive force more efficiently, and it can minimize the shear force and it can maximize the BIC. So insertion talk. Today's topic is one-day implants. To make one-day implant possible, the initial stability should be really good. So in any kind of region, any kind of bone density. So let's talk about the loose bone. We developed the rescue implant system. It was really good for the extraction socket and the limited height on the maxillary posterior area. But even we increased the diameter of implants to 8 millimeter, the initial stability increased only this much. It was good at the Eureka R1, but we are moving to Eureka R2. So we need this much initial stability at the loose bone. Loose bone means the bone, like maxillary posterior area. So by changing the design, by changing the thread shape, the initial stability increased to 35. It's enough to make a 70 or more ISP value. We have to understand how to place, how we can get this kind of initial stability. So, for the common implant systems, we're going to make the same size of hospital circuit like this at different bone densities. So, and then, according to the company's recommendation, we are going to same size of implant into the same size of hospital sockets. And then, what can be the difference? The initial stability will be different. You will feel very loose stability on D4, and you will have a really good initial stability at D1 and D2. So, what can we do next? Because we got very weak initial stability, we have to wait longer. On the mandible, we can start the prosthetic procedure in 3 months or 2 months. But we have to wait 6 months or longer at the loose bone because of less initial stability. But on the end ridge, we change the concept. So we're going to make the same size of our stiffened sockets. As you see, but you need to think. That's why end ridge is named as thinking man's privilege. You have to think as a dentist. You have to understand the bone density. But you will make the same size of the stiffened socket, and then about your filling, with your filling on the bone density, you can place different size of implant system and different size. On the D1 bone, with a hard bone, with a hard bone density, you don't need to use deeper thread. On the D4, you can place deeper thread to grab more bone. And then you will build same initial stability. That's our focus on the end ridge. So if you get same initial stability on each implant, so you can start the prosthetic procedure at the same time. Yes, this is a very powerful stages period. But now we can start one-day implants. So you can control. The main thinking is you can control the stability as you want. Some guys, some dentists want to have a really just a good stability, not very tight. But some dentists want to have a really tight stability. So you can control according to your wish. And when I explain this, many dentists, many friends of mine ask me, are you sure the bone can ingrow to the bottom of the thread? Even this much distance, the thread depth on the 5 millimeter diameter of any ridge, the thread depth is almost 1 millimeter. And about 8 millimeter, the thread depth is more than 1.5. As you know, bone cell can grow only 0.1 millimeter per month. So, if we have bone here, the bone ingrowth will take almost 1.5 years on this thread depth. So, how we can wait? So, that's the question from my friends. But if you try any ridge, you will see you will have this kind of X-ray image immediately after surgery. So, can you see any gap between the thread bottom and the bone? Already filled with bone from the beginning. So, again, you have to understand this diagram. We made the same size of the stiffened socket, and then we will place different size of implants into the bone. What is the minimal size of the stiffened socket? It should be the core diameter of any ridge. So already bone is there. So with the conventional triangular thread design, we are making contacts with bone only half of the thread depth. So the rest of half here, this space, should be waiting for bone regeneration. It took almost 3 months. That's why we waited 3 months in the past. Because normally the conventional triangular thread has 0.6 millimeter depth. So if we have contacts only at the half, with half of thread, the half will be 0.3 millimeter. the 3 level, we take 3 months. On the average, no need to wait. So let's look at again here. So this is 43, so it will take 3 months. But with average, you're going to make the same size of the socket with the implant core diameter. So there will be no gaps. And according to your feeling, we will place different thread depths. So bone will be always here, almost at the bottom of the thread. And you can extend the thread to make more bone, to get more bone tissues. That's why you will have this kind of X-ray image immediately after surgery. But sometimes we have a problem, especially on the extraction sockets. So in that case, we cannot engage all the different thread with the bone. In that case, yes, we can have this much bone defects. On the animal experiments, in 4 weeks, on the rabbit, the bone was filled. Regenerated bone was filled to the bottom of the thread. So no need to worry. So I try to show this case, very special case. I don't want to recommend this kind of practice, but just I was very excited with this case. This professor came from Hong Kong to get implant treatments, but the periodontitis and the inflammation was so severe, so I just extracted and waited 4 months. 4 months, you can say, yes, we will have some amount of bone regeneration because this is the extraction cycle. When he comes back, the clinical image looks very nice. So I opened it back. There was no bone regeneration in the socket. You just see here. No bone regeneration. And the available bone here is very limited. I cannot engage implant with this bone because of nerve. He applied to Korea from Hong Kong to get this implants. So I cannot push him back. I just placed 8 mm by 13 enriched implant without any initial stability. I just throw it. And placed some bone-grade material and covered with the glass membrane. As on the X-ray, no part of the implant was engaged with bone. It was just a stage. When I did second stage surgery, I was very surprised for bone regeneration occurring. And this is 1.6 millimeter thread depth from here to here. But it was, the whole space was filled with regenerated bone. Why this happens? It's because of new surface technology, actually. I think so. We named it as XP. XP is based on the SLA surface treatments, but we coated with the calcium ion on the surface. Why we coated this? During the placement of, during the coating of calcium ion, the implant color turns to blue. So as you know, the SLA is very nice surface treatments, but sometimes it has a dangerous acid residue even after washing. We need to be very careful. From the beginning of our company, so we had this technology, but we hesitated to use this technique on the implant treatments, implant surface treatments. But about 4 years ago, we developed new techniques with alkalization and the calcium incorporation process after acid etching. We can guarantee the safety. So with XP, we change the process and the material a little bit. But the most important thing is we can guarantee no extra residue on the surface. So I can say this is much safer than the normal X-ray process, SLS process. Blue color or SD can guarantee the safety of the microstructure. And on the SCN image, it looks almost same. This X-ray was made from strong implants, but it looks almost same. But if you see the numbers we measured on the implant surface, the RA, the average of the absolute height value of 4.05 looks almost same, around the 2 micron roughness. RT, the maximum peak to value height of the entire measurement trace was 50% less. That's why we have this number. It's because we control the size of plastic medium. So it means it's very plain, very plain. Not have a high peak and the valley. And the calcium can fasten the oscillation process. On our experiment, on the animal and cell culture, XP has a 15% faster oscillation process than the regular SLA treatments. This is SCM, high magnification of XP surface. So the difference, we can find the difference. It has some scales on the surface, small scales, like this. This is calcium. So this calcium binded with titanium make calcium titanite. Calcium titanite material on the implant surface can fasten the oscillation process. So I'd like to show this one simple case which was made by Dr. Han. So this is just our one-stage implant surgery. After implant, replace the 2 implants, 4x10, 2 implants, and then we got really good initial stability because the bone ratio was not bad. But you control the drilling sequence to get more nicer initial stability. And then he finished the case in 6 weeks. Finished the case, not the temporization. Final restoration was delivered in 6 weeks. And this is 10 weeks later. No change at all. Still, it was good. This is the effect of XP and the design of NVH. Connection is very important, as you know, to make a stable peri-implant tissue. So I showed this slide many times in Taipei, but on our experiment, 5-degree angulations connection was revolutionary strong. So we hesitate because many dentists want to have compatibility with other implant systems. But finally, we decided to have these unique angulations. Compared with other implant systems, like strong bicon, with even 3 degrees connection. 3-degree connection means 1.5 degree on each side. So even 3-degree angulations, there's only this much throughout force. But NVH is almost a double than bicon. Very strong. So if you have connections, you will never have a screws nut. Personally, I placed more than 1,500 NVH implants for the last 3 years. I had no screws now. And then my daily protocol was changed. I usually use the screw retained prosthetics. Why? was some problems always with the prosthetic parts. The most frequent complication was the screw loosening. So whenever I have screw loosening, I need to remove the wedges on the screw hole and take out, tightening, and deliver again. But if we can guarantee no screw loosening, why we have to make a screw retained prosthetics? It's difficult and not aesthetic, not very functional. So we can guarantee no screw loosening with these special connections. Maybe some of you, many of you already saw this video, but this is funny. We have to test this. Right in our office, it's connected the abutments with the fixtures, with the finger force only. Finger force cannot exceed than 10 Newton centimeter. It's very strong. And she took out the abutment screw from the fixture and tried to separate abutments from the fixture. But she couldn't. He called strongman and asked to separate the fixture. It's not lie. You can try at both. And they called strongest guy. Okay, Superman, help me. It's not easy. Almost she tightened only with the finger force. But if you tighten with 25 Newton centimeter, you will never have screw loosening. It's a big advantage. But if you want to remove the abutments from the fixtures, yes, we have a removal screw, very clever instrument, small instrument. So I'd like to introduce how difficult it is, how difficult to get initial stability. It's easy. We have 10 different diameter on energy systems, from 3.5 to 8 millimeter. But only 3 different kind of core diameter. 3.5 is 2.9. From here, 4.0 to 5.5, there is 3.3 millimeter core diameter. Core diameter is same from here to here. And from Y diameter, from the Y diameter and width from 6 to 8 millimeter has the same core diameter, 4.8. So you don't need to think about this at the beginning. If you are at the beginner on the energy systems, just think 3 implants. This will be enough. No need to think about this. So, recommended initial trial. If you have no experience with energy, try like this. You need to find out a case with a heel width, and it should be average density. Average density means, let's say, density 3. Type 3 bone density. And then, if the bone width is limited in width, you need to place 3.5. 3.5 has 2.9 core diameters. But this is really strong. So, if you follow the average drilling sequence with other implant systems, the implant can be stopped during implant placement. So, if you are beginning on the energy implant systems, you have to drill almost to the size of implant system. So, to place a 3.5, you need to drill to 3.3, only 0.2 millimeter gap. To place 4.0, you have to drill to 3.8, almost the size. And 6 millimeter or wider end width is only for extraction socket or very loose bone. So you can try 6 millimeter of end width on the extraction socket. And then if you feel something loose, it's not, the initial step is not good enough. And then you can try wider, deeper the thread of the implants, then this one, then this one. You need some experience. I think 3 or 4 times experience will be enough to understand the concept. And if you got really excellent initial stability, oh yeah, I feel, I got it. The concept, that is, you can say, breakout. I found something. And then you can try immediate loading with the fuse buttons. So, yes, when you have a really good initial stability, yes, you can try immediate loading. What you are doing now. But this is much more convenient than before, than other systems. If you have a really good initial stability with an enrichment system, you can just connect the fuse buttons. Fuse buttons was designed to be broken when it was overloading at the neck. So we need to protect the fixtures from failure. So whenever it has overloaded, it should be broken here for the safety and no damage to the fixtures. This concept started with these articles. Dr. Brunsky published the articles in 1992. In this article, he said, if the fixture has mobility more than 100 micron, the fixture will be fibrous integrated, not osseointegrated. So at that time, he didn't use failure, but actually it's failure. Yes, that 100 micron, and many authors agree with this number. I placed the implants on the D3 bone, international standard bone, with a really good initial stability, and I checked the movement, the force to move these implants up to 100 micron, and it was 220 Newton. So improvement to 22.4 kilogram force. So if you can make a weak connection, then 220, so we can protect the implants from failure. So, and we design the connections very precisely. In average, the fuse button will be broken at 180 Newton centimeter. So it's very safe. We can protect. Even you make frowns on the immediately placed implants, this connection can protect the fixture from the failure. That's a very anatomical design. This is a difficult case. I don't need to explain the parts, the design concept. You can see at the booth. This is a typical case. The lady had a 6 implant at the age of 70. At that time, I placed a 6 implant between mental frame, and I made a temporary crown immediately at the chest side. You know, this bone is very dense, so you can try immediate loading, any case, anytime, and to anyone. But upper arch is different. 10 years later, she came back with complaints on the upper teeth. But yes, I want to have implant on the upper arch, but you have to make a teeth immediately after surgery. On the medical, yes, we can do it, but on the upper arch, full mouse case, not easy. But she is precious, so I have to follow his order. I remove the older piece and place the implants with excellent initial stability. So you have to know how to control the initial stability by yourself. All implant was fixated excellently, and I connected fuse buttons. 6, 8 fuse buttons connected, and because of angulation, I prepped the plastic parts with high-speed hand chase, and I delivered the temporary crown at the chest side. It took less than 2 hours. She was very happy. It was June 2012. And 2 months later, on the follow-up X-ray, You can see the extraction socket is filled with regenerated bone. 1 month later, when I delivered customized zirconia abutments, the defect was completely filled with regenerated bone. Even I did immediate loading. Actually, this is our concept on the immediate one-day implants. You will see from next presentation. After placement of the zirconia abutments, it has a really good advantages. So you can make super changeable margins, and the zirconia abutments have really good responses on soft tissues. And this is the second temporary on the zirconia abutments made by CAD/CAM systems. And then finally, I made a full final restoration with the CAD/CAM system again with the zirconia. It was very nice, and she was very happy. And she had a taste from the beginning to the end. So she could chew, she could eat with this tooth. What happened if we have an overloading on the implant on the crown? As you see, this guy had a lot of implants for the last 10 years actually. So many different kinds of implant systems. Small skin implants, the intermediate implant, which was used for the immediate loading, was broken. This level, there's no problem. And some anyway here. Finally, recently he lost 2 teeth more, and I waited 1 month because of the inflammations. And when I opened that, I placed the 2 implants. Initial stability was good. Even there was a small amount of extraction socket defects, so I connected the temporary fuse abutments. And this is cap, easy to make. And I delivered temporary crown at the chair side, immediately after placement. But I really reduced the occlusal height. But a month later, 4 weeks later, he came back with his temporary crown on his hand. It was broken. The implant was safe. Then, as we can start prosthetic procedure immediately. So I made the temporary customized abutment and delivered and finished the whole case, all the procedure, the prosthetic procedure. It's very safe. You don't need to worry about it. It was the broken fuse abutment is not common. It's very late. It means it can be very safe, even with immediate loading. Fuse abutment, I think this is a really good experience and good tools for the trial of immediate loading. And it has many special features with a very particular designs. It's not common in the system. It's a very deep on the thread, very aggressive, and special designs. So you will be curious about the long-term prognosis, long-term survival rate of enriched systems. On this topic, Dr. Han will give you a presentation. So, let's welcome Dr. Han.
Good morning. I'm Tae Han from Gwangju Military Hospital in Korea. It's my second visit in Taiwan. First visit was for IAOI meeting about 2 years ago. Nice to meet you again. And I'm very happy to share my experience with you. As I'm one of the enriched mania, I'm trying to write an article about cumulative survival rate. Today, I'll show you some cases and long-term survival rate of enriched implant system. I've used enriched system for about 4 years. Dr. Park explained just before, I experienced so many advantages of enriched implant systems too. especially strong initial stability from unique design of NH implant system. I think NH system is very bone-friendly implant system compared to other implant systems. Therefore, I started doing a retrospective study from last year. For this study, 500 NH pictures was included in order of placement. Before I present the analysis result, I will show you my NH follow-up cases and treatment time briefly. It's immediate implant placement case. It is a favorable bone condition because it has no parietal bone and soft tissue loss. In anterior region, I prefer to place implant immediately and connect proven restoration if possible. Of course, strong initial stability must be needed. It could be obtained more easily when we use NH implant system. Most of immediate implant placement cases, I waited 3 months for final restoration. From 12 months follow-up radiograph, we can find excellent facial bone response. It's another immediate implant placement case. It has the parietal bone and soft tissue defect on the lateral incisor. Although it has poor parietal condition, I prefer to place implant immediately with bone and soft tissue graft in one surgery. And I have confidence that connective tissue graft is essential for aesthetic anterior implant restoration. After 5 months, I could find the excellent soft tissue profile. And then process was done. Usually, I wait 4 to 6 months after bone grafting, according to the shape of the bone defect. It's 12 months finding after final restoration. I have one principle for anterior implant placement. For better anterior aesthetics, we should minimize the number of surgery. Also, we should try for minimal invasive surgery. We can find a stable facial bone right back. It's another immediate implant placement case with large bone defect. Most of these situations, delayed implant placement could be a choice of treatment, but I prefer to place implant with GBR simultaneously. For this protocol, the implant design has a strong initial stability is essential. I had NH implant system at the time. And I got a good result too. It's 2 years after final restoration. How can I get a good result? I think it comes from healing potential of extraction socket and strong initial stability of NH implant. It's slight narrow ridge case with 4 to 6 mm ridge width. We met this type of deficiencies frequently. If you face on this kind of deficiency, you should consider the diameter of implant and bone graft method. But NH system can be a super weapon to overcome this type of ridge deficiency. Compared to other systems, I could save more facial bone about 1 to 2 mm around implant. To save facial bone helps simple and easy surgery. Then reduce the chance of bone break. Its advantage comes from smaller platform design. After surgery, we can see the deficiency of characterized gingiva. Usually, I apply pre-gingival graft. At the pre-gingival graft, we can find increased characterized gingiva and enlarged soft tissue volume. As a result, we can make a natural implant restoration. As a normal, I deliver provisional restoration and then final restoration. Personally, I like screw type and single type zirconia processes. From 3 years follow-up, we can find beautiful crestal bone and soft tissue response. As you see, I have a confidence about long-term stability of NH system. It's moderate narrow ridge case with 3 to 4 millimeter ridge width. How can you treat this situation? We can choose GBR or black bone graft or ridge split technique. I chose ridge split technique with NH system. The combination of NH implant and ridge split technique makes it easy to place implant within host bone housing. Compared to GBR technique, it's much simpler, easier, and quicker technique. It's a really great combination. In next session, Dr. Kim will introduce this technique for you. In this case, I don't use graft material, just use only visible barrier membrane. 3 months were enough healing period because it makes the best use of the host bone. I highly recommend this technique for you. From 2 years follow-up, we can find stable crestal bone response. To place implant into host bone is very helpful factor for good prognosis. And how about material science bone graft cases? I have 2 choices personally. First, I use short implant if host bone height is over than 4 to 5 millimeters. And second, I apply sinus bone graft technique through lateral window if host bone height is less than 4 millimeters. This case shows advantage of 7 millimeter NH fixture. In many sinus cases, I could treat the cases without sinus bone grafting, like this. I think bicortical fixation technique has good prognosis more than sinus bone grafting technique. At this point, 7 mm NH fixture has one secret. Its actual length is 6.6 mm. Please keep in mind this secret. Also in mandible, it's very useful to avoid mandibular canal. Practically, even 1 millimeter length can make big difference. I use short length implant when I face on anatomical limitation in maxilla and mandible, and I experienced successful follow-up research. Lately, I prefer to use customized attachment for interior implant restoration. Immediate implant placed and provisional restoration was done. For anterior immediate provisional restoration, I use huge abutment. Dr. Park just before explained. It's very useful item for immediate rolling because it breaks overload. It makes more safe and aesthetic provisional restoration. After soft shelling, I made the zirconia custom abutment with CAT scan. It changed its implant into natural teeth. And then, temporary crown was placed on zirconia abutment. From use of customized abutment, we can adjust the shape of prosthesis easily. Finally, I got final restoration by 3D traditional impression technique. Sure, we can use intraoral scanner. Custom zirconia abutment can be one of the implant prosthetic options. It helps aesthetic anterior restoration. For posterior implant prosthesis, I prefer to use titanium customized abutment. This case is planned flush reconstruction. I did post-surgery with enriched picture. In this case, I will give you one surgical tip. From parent view after post-surgery, you can find the cover screw with different height. According to the hospital condition, we can choose the height of cover screw. It's a very convenient item during bone graft procedure. And for panel restoration, I made titanium customized abutment. It helps multiple implant process procedure become simple and easy. Initial and 6 months after panel restoration. In this case, I used the energy system with titanium custom abutment and I got a good result. As you've seen, I like to use zirconia custom abutment for anterior implant restoration and titanium custom abutment for posterior multiple implant restoration. Sometimes I was challenging and relentless. It's my treatment style. With this kind of concept, 500 and picture was placed and solid. I collect the information from patient chart, clinical columns, and radiogram. Based on this information, I got a survival rate. According to Dr. Steenberg's criteria, I failed 7 implants. The survival rate was 98.6%. It's great survival rate, indeed. If so, it's time to check parameters one by one. Between gender, male shows some more failure than female. And endeavor shows 2% higher survival rate. I usually experience these results during my implant practice. Male and maxilla have some more problems. How about the implant length and survival rate? Against my expectation, short length implants show high survival rate. But there was no correlation between the length and survival rate. And then, how about the implant diameter? Also, there was no correlation between the diameter and survival rate, even if I used a few super wide diameter implant. As a result of implant length and diameter, it was not critical factor for survival rate. and difference of placement timing. Immediate implant placement cases shows high survival rate. It was amazing. I think it comes from strong initial stability of energy system. And difference of graft time. Sinus bone graft cases shows 4 paired implant, and GBR case shows 3 paired implant. Sinus bone graft case shows the lowest survival rate. In contrast, without bone graft and socket bone graft shows 100% of survival rate. Difference of bone density. Also, according to my expectation, I got 4 failure from deeper bone. It was lowest survival rate. In difference of initial stability, when I placed the most of energy system, I could get enough initial stability. But 6 fixtures couldn't get any initial stability, and 3 fixtures are paired. As a result, I got a 50% of survival rate. Consequently, I really recognize the importance of initial stability. And it could be very dangerous to place implant without initial stability and poor bone condition like deeper bone. Unloading period was about 4 months, and follow-up period was up to 3 years. In the future, I have a plan to extend the survival rate with this information. And I analyzed the failure time with live tape method. 6 implants were paired before loading, and 1 implant was paired after 2 months of loading. After that, there were no paired implants. According to many researches about the survival rate, there were a few failures about a year. Also, this study shows same pattern as many researches. Therefore, I expect long-term prognosis as positive as possible. One more, I'm going to discuss the regional failure. I believe long-term failure will be much more meaningful thing than just keeping survival rate. Here are 7 failure cases. The most regional failure is insufficient initial stability and use of temporal tension after sinus bone break, and graft infection. Taken together, I could feel that all of the regional failure comes from myself if I did some more careful approach. Anyway, I'll show you 2 failure cases. First failure case, it was severe bone defect case, but I planned implant placement with GBR simultaneously. It's my treatment style. I thought it could be possible to be osteointegration integration because there was stable bone housing around the implant. Inevitably, I placed implant without any initial stability. My treatment plan was overambitious. I now regret that why I didn't choose staged approach or longer implant for initial stability. Anyway, after 5 months, I removed and replaced that implant because of the osteointegration symptom. From this failure case, I learned good lessons. In case of large bone defect, first, initial stability is essential factor for osteointegration. For get more initial stability, we should choose optimal implant design, length, and surgical technique. Second, enough healing period must be needed depending on the size of defect. So this case was very regrettable. Okay, let's look over another failure case. It was four-arch implant case. Also, I chose the simultaneous implant placement with lateral sinus bone graft technique on both sides. When I was placing implant, I didn't get any initial stability on L side. In addition, I delivered temporal denture for patient convenience at the same day. 2 months after provisional restoration, I removed that implant because of discomfort. After that, I delivered final restoration using surrounding implant. It's 28 months after final restoration. So many cases with sinus low reach, we can't get enough initial stability. This failure case also had no initial stability. In this case, state approach could be another treatment option, but as my invasion, I made mistake. And I experienced the failure rate much higher when I delivered temporal denture for temporization. I think for more safe ortho integration, we should consider for temporization method to protect grafted site. Look back on my failure cases. I could be able to reach almost 100% of survival rate if I had some more careful approach. But as a result, 7 fixtures was failed among 500 fixtures. And I got 98.6% of survival rate. It was great result we did. And I think the reason why I can get very high survival rate comes from unique design of NED system. As I mentioned before, I have confidence about long-term prognosis of NED system. Thank you very much.
Thank you, Dr. Han, and thank you, Dr. Park again. 谢谢我们的 Dr. Han 以及我们的 Dr. Park 带来这么精彩的演说。那么今天的课程内容呢，真的是相当的引人入胜哦。听完了这一堂课程之后，我们可以得知 One Day Implant 这一项领先的植牙技术，可以说是确实有效的解决了过去在植牙上面的限制，也相信可以避免贵宾朋友们在临床上面所遭遇到的风险。那么如果大家有兴趣的话呢，在今天我们的会场外厅也展示了相当多关于 One Day Implant 的植牙器材以及影片，也欢迎大家莅临参观。那么今天紧接着下来，为了要感谢所有的贵宾朋友在百忙之中的参与哦，我们在您的这个挂配的名牌内放置了一张 coupon 的这个优惠券哦，那么是由我们 Mega Chain 原厂所提供相当大的优惠折扣，错过这一次之后就不会再有了，所以邀请所有的贵宾朋友们，今天真的要把握住这个难得的机会，请有兴趣的客户朋友可以多加利用。好，那么紧接着下来，我们让大家休息一下，现在是我们的抽奖时间哦。在这个阶段呢，我们要抽出10组，这个每一组市价3万元的 One Day Implant 套组。那在我们抽奖之前，我们要提醒大家，待会抽中的贵宾请尽速来到我们舞台的右侧，也就是现在我们礼宾小姐所站的位置来进行对号事宜哦。那么待会在上台领奖合照之 之后呢，我们要将这个中奖的纯根带到服务处来兑换产品领用券。那为了这个抽奖的公平性，我们要提醒所有的朋友，请带双证件到服务处确认是本人之后对领哦。那现在呢，我们要即将进行我们的抽奖时间。首先，我们要有请中华民国临床植牙医学会的周世华周理事长上台，为我们抽出10位幸运的得主。热情的掌声欢迎我们的周理事长，欢迎。好，那么到底有哪10位幸运的朋友会获得我们今天价值3万元的 One Day Implant 的套组呢？来，请我们的理事长帮我们抽出第1位。好，来这个第1位，我们请大家看一下摸彩员的这个号码，最后3码是907，这个是我们的庆长牙医的陈永兴陈医师，恭喜你！来，我们的陈医师有在现场吗？可不可以举个手？好，请我们的陈医师麻烦到我们的台前好吗？待会我们一起上台领奖，好，是不是给我们的陈医师一个热情的掌声，好不好？恭喜我们的陈医师。好，紧接着下来这个第2位呢，编号是467，那么这一位是我们的这个安和美牙医的詹医师，我们的詹医师有在现场吗？好，来詹医师，如果在的话，帮我们举个手哦。好，那詹医师，对，第2次差不多吗？OK， 詹医师好，恭喜我们的詹医师。好，紧接着下来呢，来我们第3位的是这位医师，这个摸彩券，对，特别折了一下，这位是我们编号754，维悦的林医师，我们的林国祥林医师有在吗？编号是935，恭喜我们的林医师。好，紧接着下来呢，还剩下有7位，对不对？好，这7位幸运的得主，惠群诊所的吴文斌吴医师，恭喜我们的吴医师。好，接着下来呢，来我们来看一下下一位是。好，这一位是上弘牙医的赖永章赖医师，恭喜我们的赖医师。好，请来到我们的台前。好，还有5位哦，理事长。好，来这一位是，恭喜我们的精彩的王志昌王医师，恭喜。好，恭喜王医师，请来到我们的台前领奖。好，紧接着下来呢，我们的这个瑞典牙科的吴医师，吴凯明吴医师有在吗？您的摸彩券编号是921，恭喜！来，我们的吴医师，好，请吴医师来到我们台前，好吗？好，紧接着下来呢，这一位是我们的进贤牙医的张克勤张医师，张医师有在现场吗？麻烦举个手哦，恭喜我们的张医师。好，接着下来呢，有请我们的理事长哦，最后2位，这一位是我们的季红辉医师，恭喜我们的季医师，来，季医师有在现场哦，举个手让我们知道，好，恭喜我们的季医师。好，紧接着下来是我们的这个编号435的胡医师，有在吗？您的编号是383，恭喜我们的胡医师。好，来，这是我们这10位幸运的得主。好，那现在呢，是不是请我们10位幸运的得主，我们的医师们可以上台受奖，好吗？掌声欢迎我们10位幸运的医师们，来欢迎。好的，在这里呢，有请我们理事长帮我们颁发奖项哦，这是价值市价3万元的 One Day Implant 的套组。那么当然，待会呢，我们还会有70个奖项哦，让我们的贵宾朋友们帮我们抽出来。今天大会总共准备了80项的奖品，等一下呢，我们还有70项的奖品，要请我们的贵宾朋友帮我们抽出来，请我们所有没有得奖的朋友不要气馁哦。好，那现在呢，请我们的理事长可不可以帮我们把这个奖品帮我们移到舞台的中间，好不好？好，也请理事长跟我们所有的这10位幸运的朋友，我们的医师们一起合影留念。来，我们的摄影大哥在前方，来，所有的医师们，我们的理事长、摄影大哥在前方，请看着我们前方的摄影大哥，留下一个最灿烂的笑容 ，smile。好，谢谢所有的医师，也再次恭喜我们幸运的朋友，是不是给我们幸运的医师们一个最热情的掌声？谢谢我们的医师们。好，也特别谢 谢谢周理事长的莅临。好，那在这里呢，我们请所有的医师们可以先请回座休息，也谢谢我们的周理事长请回座休息。那紧接着下来呢，除了要提醒大家，我们还有70个大奖在待会的活动当中即将陆续的抽出之外呢，在课程我们在这里就告一个段落，中场休息30分钟的时间。那我们要这个热情邀请所有在现场的朋友，一定要来到我们的大厅地里来参观。我们今天有许多的器材以及相关的影片都在大厅的现场。那么当然我们也准备了茶点，所以现在请我们所有的朋友可以移驾到我们的外厅享用精美的茶点，而且呢也要莅临参观我们今天所有的器材以及影片。再次感谢大家的参与。现在我们的接着下来下一个阶段的课程即将正式开始。那么接下来呢，我们的精彩的课程内容要欢迎到的是我们亚洲植牙教父，刚才大家也都听过他精湛的演讲，所以在这里呢，我们要再一次的欢迎我们的 Dr. Park 上台来为我们讲演。那么这个主讲的题目是 Effective Solution for Overcoming Bridge Deficiency， 让我们用最热情的掌声欢迎我们的 Dr. Park。Ladies and gentlemen, let's welcome Dr. Park.
Welcome back. The second session, we are going to deal with some new gadgets for the convenient visualization. Like give someone, and I will give you some tips for the nice visualization techniques. Yes. You mentioned about possibility to get more initial stability with enriching systems. But still, patients have difficulty. What kind of difficult problems we have with our patients? So will be enrich, 4 to 5 categories, and low reach, and loose one, like our space in the bone, and sinus pneumatization can be another problem, as Dr. Han told out there. And the socket is very prognostic defect. Still, we need to know how to deal with the socket defects. So because of time limitations, we are talking about these defects only today. So let's talk about the loose bone. Yes. Actually, this is very difficult to control. In these defects, with the thin niche and low reach, we can put some bone graft material and we can cover with many different kinds of membranes. But loose bone is very difficult to have success, higher success. hollow space. So in this case, you have to know how to control the initial stability. Any ridge can help to make a better initial stability, even at movement as I told you. The typical case, this is not very common on the mandible, but very common on the maxillary posterior area. So, let's think about the disc. It's very loose, like a spongious form, without any cortical bone. Basically, implant surgery should, depending on the amount of the initial stability on the cortical bone, reported by Dr. Senti. But in some case, we have this kind of case. Lose initial stability, and we need a longer posterior duration period at the Eureka R1 period. But we have maxillary implants. This is really good. I think this is best option for the loose bone. I need to show this case. Already, this is the best case I like. So many of you already saw this case. The patient had the 5 implants already. Recently, he lost the first molar on the left maxillary posterior area, and 1 month passed after extraction, which was healed. But because of pneumatic gravitation of the tuberosity, there was not enough space, intraocclusal space, to make ideal size of crown. So I had to remove this much bone from the crest. I think that I removed all the cortical bone to make a space. So, and then you can think the bone density very easily will be typical type 4, or if we have type 5 in the classification, it will be type 5. The worst case for bone density. So what's our treatment model in this case? I usually use HA-coated implant in this case. But HA-coated implant can make a more problem at a certain period. In my case, 5 or 6 years later, certainly HA-coated implant came with a severe bone loss. So we need to know how to control this kind of bone density. But don't need to worry about the loose bone if you have a concept of this triple thread anyway. So I like to use trephine to make an osteotomy socket on the maxillary posterior, especially when the ridge width is wide enough. I use the 4050 trephine. It means I made the 5 mm diameter of osteotomy socket with only 1 step drill. And then I placed the 7 mm diameter implants, 2 mm gap between trephine and between osteotomy socket and the fixed size. 2 mm is enough to get really good initial stability. Even there was some bone defect, extraction socket defects on the first molar. I had enough amount of osteotomy stone harvested from the crest. So I put osteotomy stone and made the primary approach only without membrane. And in this case, how long we should wait? Bone was type 5, very loose, but I got really good initial stability like mandibular bone. So, how long we should wait in this case? Usually, if we don't use this kind of implant system, if I use this kind of implant with a regular thread, so we have to wait more than 6 months in average. If you can make initial stability, like mandibular bone with deep in the thread and a lot of surface areas, you need to wait longer. Just you can start prosthetic procedure 3 months later, like mandibular bone. Sometimes earlier, but I don't want to challenge too much with our precious patients. So I waited 3 months and we made the second stage surgery and delivered the temporary crown. Finished the whole procedure in 5 months. So this is normal process. Don't need to worry about it. Don't need to scare about the loose bone. So this is simple solution. So just we can control the initial stability by using different different depths of the thread. Okay, let's move to the thin and low ridge. It's a big challenge to us. If you can solve, nowadays science is just easy to solve and very predictable result. If you don't use temporary denture too early. So, yes, let's start with this slide. This patient had many different kinds of bone defects. Dehiscence defects on the right side, fenestration at the middle, and the large extraction circuit defects on the left side. How we can solve? Which technique we need to use to overcome all kinds of these defects? Of course, on the literature, you can find many detailed techniques and materials to be used for each defect. But in general, if you have all defects on one patient, what kind of technique we have to use? It will be GBR techniques. We need the bone graft material, we need membrane, and make a primary very good soft tissue management. So we need to do bone graft on the ridge defects. Usually on the literature, they say 30% or more than the ideal ridge bone, considering the tissue shrinkage during remodeling process. And then we replace cortex membrane or long-lasting membrane, and we make a releasing incision to make a adequate tangent suture. Yeah. 3-layer suture is very important, but without tight sealing, we cannot make bone, as you know. So we have to know how to make a primary closure. I recommend to do 3-layer sutures from here to get the periosteum in the buccal, go back, make high. This is first layer suture, and then between incision line and first layer suture, we need to start second layer suture. You can use a vertical piece or horizontal method sutures for these purposes. And for the last 3/4 layer suture, you can use any kind of suturing technique. I like a continuous locking suture. Yes. Through this 3-layer suture, you can make a watertight sealing on the incision line. And then you can wait, just waiting for the bone regeneration. Actually, we are not regenerating bone defects. We are helping the bone regeneration. This is a panoramic view after surgery, and 6 months later, when I opened the bed, it looks really wonderful. All the bone defect was covered with the regenerative bone, and I simply changed the cover screw with healing abutments and made a tight sealing against the healing abutments for the second stage surgery. And 2 weeks later, I delivered this temporary to the patients. So the patient started from this stage, and in 6 months later, the patient had this result. Now, of course, this is not permanent restoration, but patient was really happy. And then this was X-ray after delivery of the temporary crown, and after trial of the temporary crown for 2 months. Because this is fully dangerous case, we need to give enough time to exercise by the patients. And finish the whole procedure in 6 months. And the panoramic view after delivery of the final restoration. As you see, the bone level was perfect on the crest. Yes. It took almost 7 months, almost 8 months from start to the final restoration. And then it was good, not perfectly ideal, but it was acceptable, and the patient was very happy and very well functioning. But on the follow-up period, not only me, you may have some problems, some complications. It starts from this area. recessions. Even the follow X-ray shows almost the same crystal level with the finishing, finishing stage of final review. But we have some problem compared with the photos in the delivery of final restorations. Why this recession? So when this patient complained about me, doctor, I have something already in my eyes. So the letter started to expose. Why this happened? I break. No, you cannot break me. So I did a lot of things to you, for you. So this is just normal. Don't bother me. You have to know why. This is a small thing. But all the complications start with these recessions. So we have to know why this recession occurs. I think it's because of tissue biotype. Tissue biotype have two factors. One is bone, the other is soft tissue. So we have to make thicken the bone or thicken the mucosa, at least one. Or if we can make both tissue thicker, yes, it will be the best. But at least we have to make bone. And then, if we cannot make enough bone, we are making thicken the gingiva, thicken the mucosa by pre-gingival graft or connective tissue graft to increase the tissue biotype around the implants. So we have to have thicken the tissue, better tissue biotype. So we need to ask ourselves, how much bone we need for the long-term prognosis, not just the failure and the survival, for the function and this kind of beautiful aesthetics. How much bone we need? I'd like to invite Dr. Kim Sang to show you what is the ideal regeneration. Please welcome Dr. Kim.
谢谢我们的 Dr. Park 为我们带来这个精彩的介绍。那么紧接着下来呢，我们当然还要再欢迎到我们这个 MINAC 研发团队的重要团队，也是呢我们享誉国际的知名牙医师 Dr. Kim Chung An. Ladies and gentlemen, let's welcome Dr. Kim. 给我们 Dr. Kim 一个掌声好吗？
Thank you for having this introduction. Ladies and gentlemen, dear my colleagues, good to see you, and I'm honored to be here in Taipei, Taiwan. I'm from Daegu, South Korea. I'm one of the members in the Megazan implant faculty group. I would say a bone, a most important part of implant dentistry. What do you think about bone quantity around implant? How much of bone do we need to make? As you see, this is newly formed tissue around implant with non-usable membrane, like Gore-Tex membrane. Is this a regenerated true bone? How do you think? If so, what shape of bone we need to make for implant? From now on, let me introduce you about my concepts of bone around implant. As you know, after extraction of teeth, we often meet this situation in the atrophic alveolar for implant treatment. And Dr. Nojawa group and Dr. Grunder suggested biotype of peri-implant tissue must be different from natural teeth. So we have to make more bone tissue around implant than natural teeth. Especially Dr. Grunder, he suggested the buccal bone width of implant was more than 2 millimeters, preferably 4 millimeters.
Okay, again, let's assume there is a bone defect as looking like this. According to many articles, we need to obtain at least 2 millimeters of buccal bone thickness for maintaining stable hard and soft tissue. Using non-supporting membrane, like collagen membrane, often has problems. Directly speaking, it doesn't have any ability of space maintaining, although we commonly use the graft bone materials and membrane. As you can like this, if you use the non-visible membrane without titanium reinforced structure, if you as you saw this resorption is occurred. So the typical mistake of non-supporting membranes have some problems. Therefore, applicating this non-supporting membrane often results in larger amount of bone resorption due to lack of space maintaining ability. In other words, the resulting of using non-supporting membrane is not critical. How about Dr. Grunder? What is his concept about this? Let's examine how he overcome bone defect like this same situation. As you see, he grafted a large amount of bone materials looking like this. Considering the remodeling shrinkage amount of bone, the bone occlusal radial angle of which should be close to right angle. Then he used famous or notorious how to handle titanium reinforced cortex membrane to acquire sufficient space for bone regeneration around implant. The result was good, as you see. And there is a real bone resorption in the grafting site as natural. Even though titanium reinforced supporting structure, compared to using non-supporting membrane, Dr. Grunder obtained enough bone, as he shown in his article. However, depending on various defects, it is obviously difficult to control particulate bone substitutes and to modify titanium reinforced cortex membrane. Also, there is another factor to consider, particular direction of remodeling of augmented bone. What should it be for ideal regeneration? Best important thing is space maintenance or maintaining ability. As I mentioned before, to avoid the common mistake of using non-supporting membrane, the vertical space maintained must be at least 1 millimeter whatever membrane is used. There will be from 0.5 to 1 millimeter remodeling shrinkage of augmented bone. So this remodeling shrinkage should be considered too. Considering this shrinkage, the horizontal extension needs to be more than 2 millimeters of buccal bone width. Blunt 100-degree angle will be helpful to avoid soft tissue irritation. To adapt the membrane to the bone, an apical skirt is necessary. these important factors are all boxed in ISAN membrane. Vertical part, 100-degree angle, apical strut part. For localization for particulated bone, far cover margin is pre-banded for easy application. Even though ISAN membrane was used, a little bone remodeling shrinkage can be offered. Because the membrane was designed to consider this shrinkage, the amount of regenerated bone we want is protected. As you see, depending on various defects, ISAN membrane fully covered the defect by various designs. Let's watch a short movie of overcome the deficiency defect around implant. One patient had first premolar missing, so we waited for about 1 month for soft tissue filling. So we scheduled implantation with bone augmentation procedure. You can guess that the picture is an enriched implant. For application, ISAN membrane, plate allotment is set. Next, bone augmentation with megas bovine, xenograft, and ISAN membrane is applicated, and after that, the cover screw is screwed. If you do that, the membrane holding suture is not necessary. After 3 months, simple horizontal incision is done for a removal of membrane. Cover screw is unscrewed. If you unscrew the plate allotment, ISAN membrane is automatically upward move. So you can easily remove the titanium mesh membrane of ISAN. You can identify the fascinating result of bone augmentation. Okay. Let me introduce to you another case 1. A patient has a missing side from central incisor to second premolar on left maxilla. For flap handling and primary closure, I waited 1 month at the extraction. Next, the incision and flap elevation was done. After that, enriched fixtures were installed inside of central incisor canine second premolar with good stability. using IgM membrane, connecting the flat abutment to fixture was done. After that, the IgM membrane was set to fixture, cover screw was connected. For non-covering bone graft material, collagen membrane was covered and sutured. You can see the good outcome panoramic view of this implant surgery. Healing was uneventful, was good. After maturation of bone substitute, removal of IgM membrane was so easy. As I mentioned before, by unscrewing the flat abutment with the driver next to removal of cover screw. The surgery doesn't need any vertical incision, only horizontal incision is necessary for that surgery. These automatically simple procedures of removing membrane provide protecting the regenerated bone by minimally invasive trauma on the side. Each periodical view of 1 week, 1 month, 3 months, 6 months show you maturation of the bone grafting materials around the implant fixture. After that, CT radiographs give us a surprising result. Can you see that line? There is neocortex. Our final goal for bone regeneration through remodeling of bone substitutes. Thanks to potent scaffold of IgM membrane on both medial and distal area, in the covering site with collagen membrane, we could find good results as expected. From now on, let me introduce the hot movie just before 1 week, 2013 Megagen Symposium in South Korea. I performed the live surgery just for 15 minutes using IgM membrane. The patient have missing on first femora on right maxilla. This here. The defect morphology was so complicated with a palatal defect. This photo shows you healing status of tissue 1 week after extraction. Because we want to uneventful healing of soft tissue after bone grafting, so we waited for 1.5 months. Treatment plan was first N1 implant placement using any-guided system for precise positioning of implant platform. Second, bone grafting with IgM membrane. Let's start. Incision and degranulation procedure was done before starting surgery because of a limiting time of 15 minutes. you can see the vertical and distal two vertical incision, buffer and palatal. So degranulation is done, and you can hear and learn about the anti system in next session. I use it for precision of platform positioning. Increasing drill size sequences continue for 4.0 13 millimeters implant picture. As I mentioned before, this situation is implant positioning is decided, and I install the fixture protruding by about 3 millimeters. Latchet connect for deliver of fixture. Using handpiece and install the fixture. You should match the hexa position and the platform top. So upper indicating line of any guided stand and the lower indicating line of the connector. If so, you can install the fixture scheduled position. I obtained a good initial stability of torque over 50 newtons per centimeter. For applicating nitrogen membrane and connect the plate allotment of 2 millimeter high. So Megas bovine and Megas allograft. Megas is mixed with venous blood for particularly for handling. If you do like this surgery, you do the over build up convert material. It's good next to stand. You can see the flat, positive form of flat abutment. This part is connected as a membrane. As I mentioned before, as a membrane is very various height depending on the defect size. So this size is necessary for the lingual cover, so I choose the C2 type of IC membrane. You can see the lingual extension. And then cover screw is applicated. You can see the wide angle form of IG membrane. This excess material of bone substitutes is delivered dead space of upper side. After that, suture will be done. I prefer the vertical matrix suture for large amount of bone augmentation like this. I check the approximation of both of margin. After that, the vertical incision is sutured by simple interrupted suture method. Okay. Initial photo and post-operative photo show you a primary closure was done, and this vertical matrix, single interrupted suture like this. So primary closure was done. As you see before, the pre-op radiographic view show you like this. Post-op panoramic view show you exact position of what I want. Can you imagine this situation? Let's review this procedure of movie with me. First, I analyzed the defect morphology and selected the type of C2 of IJ membrane with lingual extension. After that, I installed the animal picture. I connected the flat abutment for using IJ membrane. Megos of allograft, megos bovine of xenograft mixture was applied. IJ membrane. I then cover screw. Yeah. A few months later, I will have a good result of these procedures. I want to meet you again with this good result. Yeah, thank you, dear.
He introduced about the basic principles, how to use, how to apply the IJ membrane, what kind of membrane we need to choose according to the defect size. I will show you one more case with video. The patient had period defects on the two incisors and the deep caries, severe caries on the canine area. So, in this case, it's not, and the patient wants to have teeth immediately after surgery. It's very challenging. But we have a fuse abutment and we have IJ membrane to make a provisional restoration possible. The teeth was extracted, and incision line in this case is very, very important. Even there is a thick granulation tissue inside the extraction sockets, we need to keep it. It's not healthy, but so we need to utilize the root granulation tissue to make a tight sealing. So this design was made on the pedal side here, and I reflected all the layer of that, including the granulation tissues inside the socket, extraction socket. You can see the granulation tissue from this area moved to the labial side with the labial tap. And all the remaining granulation tissue was removed from the socket. As you see, there are huge extraction socket defects. But this is the extraction socket defect. It's very good for the regeneration, very powerful. But on the central side here, there was no bone in vocal and no bone on the lingual side, only at the apical area. So we cannot do immediate loading in this case, in this area. So I placed the 3 implants, as you see. So we need to consider the bone remodeling amount when we place implants. So we have to control the depth of the position of the implant platform. So I placed the 2 millimeter under the thin cortical limbs around the extraction sockets. And then I connected 2 fuse abutments immediately. And as you see in this insider implants, almost half of the picture was exposed to vocal and the lingual side. And I grafted I used the same bone graft material as Dr. Kim with the venous blood. And I chose the C1, A1 type of IJ membrane in this case. Because on the pelvic side, even there was no cortical bone, so we have a very thick mucosa. So it's very helpful for the regeneration. In this case, we can use just the plasma membrane for the regeneration. So, especially in this case, we have to keep the space from the surface of the implant to a certain level, certain extent to the labial side. This role is very important. The role of IJ membrane is very important. And on the other side, we have just extraction socket with cortical bones. So we can well as membranes to protect the materials only. And this is the immediate extraction case, so we don't have enough soft tissues on the breast area. So we have to do one-stage surgery in this case. I made a primary closure, tight closure against the healing abutments and the fused abutments. And I connected the caps, fused abutment to cap on the fused abutment. It makes the temporary prosthetic procedure very easy. And then I connected the pre-made acrylic shells on the base mouse. And I will show you some videos on this process you can easily understand. And finally, it was delivered, temporary was delivered. This is video. So I used the enriched implant, as a membrane, and some fused abutments, and two different kinds of bone materials. This is for extracted. During the extraction process, you need to be very cautious, not to break the radial plate. Especially in this case, there was decay, so I couldn't remove remaining glue with the forceps. I used this was periodome, and I loosened the glue a little bit, and then I used the forceps to take out the remaining glue. And this process is very important. You have to clean the adjustment, the glue surface. The planning procedure is mandatory. Okay? It's easy to imagine the future prosthetics, the future prosthetic contours, and it should be just in the middle of the future prosthetics. Actually, on the maxillary anterior area, it should be a little bit parallel side. Features were placed with excellent initial stability, especially in this area, in the canine, first central incised in this area. So, as you see, there is more bone on the lateral side and the lingual side in this case. On the fused abutments, there are 3 different angulations, straight, 15, and the 25 angulations. So it's very easy to make a temporary restorations. Now we can graft. This is Megalos allograft. This is Megalos bovine bone. And this dimension is very important, as Dr. Kim explained on the diagram. So we have to have at least 2.5 millimeters from the implant surface to the labial side. And even we have some shrinkage, at least we will have 1.5 to 2 millimeters for the bone with the new with maturations. And because I had enough granulation tissue here, so I could maintain the tissue volume on this area. If you have this kind of case, don't remove the granulation tissue. You can utilize it to maintain the tissue volumes on the other side. And I connected the caps. There's the caps for the agent membrane. And this is what I made before treatments. I took impression and I asked my lab technician to make the shells. And you can use curing agent, light fluoration. And then when you cure a bit, you can have caps inside the impression shell. And then if you have some voids, you can add a little bit more fluorescence to make the margin thickness. Because of the shells and the caps, so you can make a very precise marginal thickness of the prosthetics. And the healing was very uneventful. So several months later. Actually, this is 1 month later. So the patient was very happy with the temperament. Not very aesthetically, but much better than the clippers. 5 weeks later, the membrane was shown through the gingiva, but was not operated. So on the intraoperative web, so you can see the bone was healing very nicely. Think about the bone defects at the beginning, and think about the bone better here. Even I did the one-stage approach, the bone was healed. It's very nice. This is very, you can have this kind of picture, X-ray image with different techniques, but the more important thing is the labial side. So you have to have a certain amount of bone from the labial side of the implants, especially on the anterior area. So a few months later, I'm taking out those the membrane and taking equations immediately after the second stage surgery. I removed the filling buttons, and when I unscrewed the fuse abutment, the membranes came out. And you can take out easily. You don't need to open the flap. This is one more advantage. If we open flap after regeneration, after use of membrane, like a vortex, the opening flap itself can damage the regenerative bone. So you don't need to open it. And they can minimize the visit, the patient visit. So after taking out the membrane, I took impression for the customized abutments. And I made two simple shifts and connected the temporary fuse abutment again and delivered the final temporary crown. And the patient still use temporary crown. On the next visit, she will have a customized abutment on each implant, and I will deliver the second temporary crown, which will be made with the CAD/CAM technology. And I found something interesting photos on the recent journal of COIR. This is one of the famous journals in the world. Not from the article side, on the advertisement page, I found this membrane. Okay? This is one of the next candidates for the vortex membrane. All companies have to produce the dental products, so we need to find something. If the next options, side crust, they say they are the next. When I saw the pictures on the advertisement, there was something wrong. See? They made an implant placement like this, and made after preparation, and they put some bone graft material. I know this bone graft material. This is locally irradiated cancer bone, which was made by Lockheed Martin Dish Bank in the United States. I like this bone graft very much. I used it for more than 10 years. But if you use this only on this cortical bone, you will never have a bone. So you need something more. You have to mix with a slowly resorbable or non-resorbable bone graft material with this material. And okay, it's okay. You can wait longer. And he placed the crust. But this is not good. You know, the most frequent complication comes from this gap. And then, what was the result? It was good, looks good, but when I saw the final restoration, they analyzed this case. Look at this. This was exposed. Implant surface was exposed. It's the start of disaster. You know? And the maturation was not done in my mind. In a very unmatured bone. If he starts the prosthetic procedure on this bone, immediately he will lose the bone resection will start. I cannot think this case can be successful. So it should be very easy. And in my mind, I used the same thing for more than 10 years actually, but I changed my mind. We have to have coverage. We have to have coverage on each implant adequately. So if we use the one-piece membrane, it looks like good. It looks good, but as you see, in some case, in some implants, the regeneration cannot be enough. We need to cover each implant according to the bone defect shape. And I try to advise you to use the short implant in this case, rather than the bone augmentation vertical. This vertical bone augmentation will make more complications. Very difficult to control. It's difficult to have a good prognosis. In this case, I will place short implants, and without making higher, very big vertical defects. And I will make it's only 1 or 2 millimeter vertical defect will be fine, easy to be restored. I think this membrane is not good. It will make almost the same mistake with the vortex membrane. Yes, on the maxillary arch, usually, in most cases, we showed you vertical defects or defects on the maxillary bone. But on the mandible, the cortical very dense and very little amount of blood supply can make a problem on the mandible thinning. In this case, of course, we can use GBL techniques, or we can choose rigid split techniques. On the maxillary arch, of course, on the research, we can find many articles to show the really good results, excellent results with the rigid split techniques. But we need to be very careful, because when we make a rigid split of maxillary anterior, especially anteriorly, the bone angulation, tissue angulation can be too much later after rigid split. So you can use, but I don't want to recommend you to do rigid split technique on the maxillary arch. But on mandible, I don't want to recommend you to do GBL on the case like this. GBL and the rigid split technique can be compared like this table. So on mandible, especially on mandible, rigid split is much more effective. Why? Because the thinning of the mandible has a thick cortical. It can withstand the force during implant placement or during rigid splitting techniques. On the maxillary arch, it's very difficult to withstand the insertion force of fixtures. So you will have more fractures, creative fractures on the cortical bone, especially on the maxillary arch. Rigid split is not a special technique. It's not a new one. It was published in 1992 by Dr. Simeon already, and hundreds of articles for this technique. Really good techniques, but it was not really easy in my experience. We had some problems. I had some problems. They recommended in the literature, on the textbook, and my teacher also recommended me to make bony cuts like this. This is essential. Also, 2 vertical incision was essential, and sometimes they recommend to make a green stick shallow bony incision at the apex of the bone here to make a green stick breaking. This incision, bony incision, can make a big disaster. If you make some mistake, the whole backbone will be separated, and then cannot place implants. You cannot make any initial stability. So you have to wait 6 months again to wait the bone regeneration. Why does this make difference? Even we know the excellent result from the rigid split technique. What problem we have? We have the implant system, which is not mentioned with the rigid splitting. And also, we have difficult machines for these techniques. Both has some problems. The first problem was the first and the most important problem comes from implant design. What? There is 3 three problems. The first problem comes from that part here. Yeah, think about the diameter of the apical apex, diameter of apex of implants. If this is 4 millimeter, it will be more than 3.5 or 3.3. And think about the patient ridge. The ridge, thin ridge, have less than 2 millimeter at the top of the crest, right? And how we can engage this apex to the patient bone. Even we made the bony cut, still it's less than 2 millimeter. And so we use the ridge split technique. No, we use the chisel and mallet to make a space for this diameter. During this procedure, patients can be scared. Oh, I don't like hammering on my hand. And during this process, sometimes you can make broken cortical bone. It's very difficult. It's very difficult to control. But that's why we made the apex of the ridge very narrow. It's only 2.3 millimeter at the apex. So you can start to place this implant, any kind, 3.5 or 4 millimeter, or sometimes 4.5, as same apical line, 2.3. So yes, you can make a drill, 2 millimeter, 2 millimeter, 2 millimeter drill, and you can try to place. You can start to place implants immediately. Even we didn't make the vertical cut here, implant itself can expand the bone. And as I told you, we need a very frequent, very strong cortical bone in this case. If we don't have a strong cortical bone, like a maxillary arch, yes, you will have a meniscus fracture here. Only, I try to recommend these techniques only on the thin mandible case. As you know, in most case, mandible ridge, mandible posterior area, has thin ridge. It's very good and can be very popular in your practice. So, it's my idea, our idea for the ridge split technique is like this. We don't need to make vertical cuts, just make a horizontal cut to the depth of the implant length. If you want to place 10 millimeter long implants, you have to cut to the depth of 10 millimeter. And then a small offset is recommended. Small offset. If the bone density is very hard and if the ridge is very narrow, small offset is enough. In this case, I didn't make just a horizontal cut only. At the 2 millimeter ridge, you can start to place implants. And my 40 Newton centimeter handpiece stop usually at this level. If you try to place it down with hand range, it will stop. If you didn't cut the bone. But you already made the bony cut to the depth of the implant length. So if you use the hand range one by one, 1 full ton on each implant, implant itself will expand during with the implant placement. The second problem is the straight design. Straight design can make cannot expand the bone. So we have to prepare the bone before implant placement. So that process is really complicated. The more problem is here at the top. As you see, if we completely place the implants, the cortical bone at the very edge, at the very top of the ridge, should be free of stress to make a bone regeneration. But if we use this kind of implant or other implants, which has the widest area at the platform, still it keeps stress on the bone, very weakened bone. So sometimes we have a severe bone loss after successful ridge splitting. But as I told you, so we remove the thread we remove the first thread from the platform. So when it was placed down, when enriched implant is placed down, it can expand. But when it was completely placed, the cortical bone, the crystal bone, can be free of tension. So it can be very helpful for the successful bone regeneration. So bone incision is another problem. The patient has less than 2 millimeter thickness at the crest. And then if we use too much bone, too thick foam to make a split, it's a waste of the bone. So we have to use the thinnest ridge, thinnest bony soul to make a splitting. We are using ridge split technique on this very thin ridge. So if you use this EMS soul tips, which has 0.7 millimeter, 0.8 millimeter thickness, so we lose almost 2/3 of the remaining bone at the crest. We made the bone as thin as possible, almost 0.3 millimeter. If you compare the bony cuts, it was made by EMS, this was made by work. As you can see the difference easily. This is really good matching with the ridge split technique, especially for the manual. And yes, if you can use any ridge, no need to make vertical cuts, no need to make take a risk for the broken cortical bone. This is much easier than the GI techniques, especially on the manual. So this patient was 79 years old, almost 80 years old. Suddenly, she wanted to have implants. You can imagine the bone condition easily. She used the denture for more than 30 years. As you see, the ridge was very thin. This is 2 millimeter of splitting socket. So you can imagine how thin, how thick the ridge is. It's almost 2 millimeter. In some case here, she had a little more bone, so I made a 2.9 millimeter fillet. Just with horizontal cutting with the patient. But we have to cut two types of implants, as I told you. So in this case, I placed a 7 millimeter short implant, so I need to go to this level. This is 4, 6, 7, 8. So I have to go to this level. In this area, I placed 8.5, so I have to go to this level. And then 2 millimeter blade is enough. If there is more bone, okay, you can try the next drill. And easy to make splitting, easy to make implant placement. Or is really simplified base machine. Actually, I think this is the smallest base machine, but much easier, much stronger. The 40 Newton centimeter end piece will start at this level during implant placement, and then I'm going to use the ratchet wrench to place it down. Yes. It's going to turn one by one. If you want to place this implants completely, and then if you try next, okay, you will have more resistance. So one full turn and the next one full turn. You can gradually expand the ridge. It's going down, down. That's complete place. From the top view, you can see the difference of the implant size and the ridge width. With the implant placement, it was this much. Please, from here to here, it takes 5 minutes, less than 10 minutes if you try very slowly. And the cutting the bone need only 5 minutes, less than 10 minutes actually. This is not soft tissue, so you need to have patience to cut the bone. Sometimes I have complained, yes, the toe is not strong enough, but it's very thin. It can preserve bone. Our purpose to do the ridge split technique is to preserve bone. So if you spend 2 minutes more, you can save much more bone. Making horizontal cut, it will take 5 minutes, or less than 10 minutes. Placing implants will take 5 minutes, or less than 10 minutes. So in total, from cutting to placement will take less than 20 minutes. It's my experience to place 4 implants. 3 implants. And bone grafting is always recommended. Any kind of bone graft you can use. And plasma membrane can be helpful again. The primary closure, I try to lie. So you can do one-stage surgery because the initial stability will be really good. But until we have enough experience on the bone behavior, it's better to make primary closure. And how long you need to wait? Less than 3 months, in my experience. 3 months is fully done. 6 weeks later, I took X-ray, and the next visit, I made the second stage surgery, and on the first month, I'm taking impressions. 2 weeks later, delivered the temporary, 6 months, finished all the procedure. This is another case, 74 years old man, similar, very similar. But in this case, I'm trying to show you how wonderful the average is. Too softish, not the bone. Well, already you realize we can manage a thin ridge of the mandible very easily. If you use a edge machine and a very thin saw. So I made a complete cut and the 2 mm drill. Here I use a 2.9. And I tried the 4.5 millimeter. Actually, you don't need to use the 4.5 in this case. Bone is very dense. Just I try. If I jerk, put strong forces of the implants, I try to see what's going to happen. So this is 4.5, and start at this level. So you can compare the size of picture and the width with the width. I placed it with I placed it down with the hand range. It was placed. Small, basically fracture occurred. Anyway, it's not far. Much better than simple ridge augmentation process. And bone graft material was done, and plasma membrane and the primary closure was made. And the other side, the same. As I mentioned, in this case, you need to watch this area. During placement, the bone was broken, but when it was completely placed, the bone went back spontaneously because there was no stress on the crest. And the same, plasma membrane, finished the case. 4 months later, I made the second stage. Look at the soft tissue. There was a very limited amount of keratine tissue. In this case, we have to have free gingival graft to make a thicker gingiva. But with enrich, I don't have enough time to explain the geometry advantage with enrich. But anyway, you can remember this. See, look at this. Bone regeneration was very nice. I just split it, the remaining keratine tissue into 2. And from here to here, it took only 3 months to get the bone. Here from here. 3 months. And I try to recommend you to use small diameter milling mat, even at the posterior molar area. If you use a bigger diameter milling mat to make a better emergence profile, you will lose all the remaining keratine tissue. And when I deliver the final restoration, if you look at the keratine gingiva here, bone is really fine. Already we made bone. But keratine gingiva was not enough. The follow was really bad. This is another advantage of enriched implants with a double offset here and there. And the follow. So I'd like to show you how to use door on the thin ridge. This is the workshop. This video was made for the workshop. This is how deep. It's very similar with mandibular thin ridge. We're going to place 3 implants here and here and here. You can have experience with this kind of workshop. The cowl rib is quite hard. This is really similar with the mandibular thin ridge. So we have to cut at least least 5 millimeter more, or probably 10 millimeter more from the distal side of the last implants. So, from here to here, is 40. So at first stage, you need time. You need to cut, you need to make lines. And then when you approach the cancerous hand, it will go very fast. And as you can have the calibration, you have the calibration here. So we're going to place 10 millimeter long implants. So you have to cut the bone to this level. So already made. Only one crest of bone, crest of cut, original cuts. And in this case, I had a little bit more bone compared with the real human case. So I made 2.9 millimeter drill. I think we can finish in 10 minutes. Sorry for that. And at the 2.9 millimeter drill, I placed a 4 millimeter diameter of implants. As I told you, even we didn't make the vertical cuts, implant itself expanded the bone. It's really amazing. So mandibular thin ridge is really heavy. It's a GBL technique, just a simple bone graft with a plasma membrane doesn't work. It can work on the mixture areas, but on the mandible, it doesn't work at all. So if you make such a simple cut and place implants, it will work. So we need some bone graft material. Anyway, you can use any kind of bone graft material, as I mentioned, with IGEN or with the registry technique. As you know, autogenous bone is always better. If you can harvest some amount of autogenous bone, you can mix with synthetic or bovine bone. We made very interesting guesses to harvest the autogenous bone. So it looks like a straight line, but it has an ice shape at the edges, at the tip, and the cover. So you can imagine, and it has this upper at the first 4 millimeter here. So you cannot go further. Just it will stop at 4 millimeter. 4 millimeter means thickness of cortisol. So no need to worry about anatomic structures. Even you use this at the mandibular, and here the mandibular canal. So when you use this, you have to match the bottom of the cover with the bottom of the orthomax. And this should meet perpendicularly with the bone. If you have a gap here, if you apply this with a gap here, the ground of the bone will stretch out. It should meet perpendicularly, and then go straight. Takes less than 10 seconds. And you will have a really good amount of bone, really good particle size autogenous bone. And you can mix with other type of bone. Let's see, just a few seconds. So you can extend. You can extend this line to the vertebral area, and then you can find the most flat area. It doesn't matter where. So you can find just flat area and then apply, because it will stop automatically, not further engagement into the dangerous area. You can find this one. And you can try 2 or 3 times on the same size. So let's go, let's move. So it's very easy to do. 10 seconds will be enough. And you can use this same automax 5 times or more. Sometimes I use 10 times. Let's see the workshop a little bit more. So we have 4 different sizes of automax. With the increase of diameters, the amount of bone harvesting will be bigger and bigger. Much bigger. 3.5 millimeter, that's this much autogenous bone. But if you have a wider flat area, you can use 5 or 6 or 7 millimeter. If you use use 7 mm diameter automax, you will have 1.5 cc of 1.5 cc of autogenous bone, articulated autogenous bone. It will be more than enough, actually. So this is the case. Actually, Dr. Johnson Lee to show the efficacy of automax. He placed one implant at the posterior, the second molar area. At the placement, he found the bone was right now. It looks right, but this area was thin, too thin. So if we make primary closure, so we will lose some amount of bone vertically. So he made operation and extended a little bit, and made one automax. See? On the superficial bone, you have this is flat. The whole piece, the whole space of the automax was filled with the automax bone. And he mixed it with the PRF, and he grafted it here, and covered it with the cross membrane. This is just a simple trial, but it will be very helpful to the patient's implant. And then, several months later, the image was really good. So you can see the image profile. It's because of the bone he made on the local side. So compared with this, he made a really successful image profile, even at the second area. Yes, I need 3 minutes more for the surprise gift to you. This is a 911 gift. You know, what is the 911? It's the emergency call, right? So we made a very intelligent case to cover the emergency case. Whenever you have some broken screws, broken abutments, or the bone association around the implants, we can use 911 kits. There's four different sections. The first section is implant section, implant capture. If you have a bone loss here, you have to remove and to place a new one. In that case, if you use a trapine, you will use more. It's very difficult to try new implants immediately. So in that case, you can use this. These screws are different directions. Yes, you can read the guideline, the textbook. So it should be fixated with 40 Newton centimeter. It should be fixed very strongly. And then this is fixed remover. It should be placed with counterclockwise motion, and then we can find a very strong latch bench. This latch bench was designed for more than 300 Newton centimeter. So we can turn to the counterclockwise to remove the feature. It's fitting implant. It should be failing implants. But in my experience, if you have very strong connections here at the apex, more than 5 millimeter, it's very difficult to take care of. But it works very well at luxury implants. Also, we have bruise. We have lost. If you have bruise on the hex, is an hex surface. Or if you have a problem on the implants, other studies, you can use solver. This is very strong metal, actually. You can screw it down clockwise. Use of excessive force may traumatize the fixture. You need to be very careful. Anyway, you can take out abutments easily. Actually, not easy, but much better than removal of the whole implant. Next is if the hex of the cover screw or abutment was destroyed, you can use the same material. It has different diameters. Okay, so we can use this. This instrument, we can make a screw again, and we can take out. We need some experience to utilize this diamond kit efficiently. And the most useful part is a screw solver. So we have many cases with the screw fracture. Right? So if the remnant of the broken screw is remained inside the fixture, it's very difficult to see and to remove. So in that case, you can use you need the two instruments. And the removal of the buttons, screw is in there. This is guide. You have to use this, not to broke the internal hex. This will guide screw solver. And we can use this screw solver with handpiece, slow speed handpiece. With counterclockwise, the tip can bite the broken screw and can remove. We have to use a slow speed with the pressures on the screw. And then when it was loosened, you can take out the pieces, or you can use explorers. I'm using this. Sometimes it works, sometimes it doesn't work. So remember, anyway, as idea in the systems. This, if you understand it, you have to understand the character of the language to continue the one-day implant protocol. Every part has some special meanings. With the limitation of time, I just prescribe thin ridge, knife edge, thread, and thin apex, and bisectory connections, not complete. So remember IGEMs, or ideal regenerations. We need to keep the space for the space management is more important than any others. And before, on the mandibular thin ridge, I never found a more efficient tool than this. Connect, just a so-so, but will be very helpful if you want to harvest oxygen. Thank you. Sorry for the delay.
Thank you so much for this visit. Thank you. Just hand it to me. Thank you. And thank you, Dr. Kim again. 好，那么谢谢我们两位非常精湛的这个演讲的内容哦。那大家应该也可以发现，这个 One Day Implant 这项植牙技术，最主要靠的就是 DDS 精准的数据分析之后所制作出来的 surgical scan， 可以让我们植牙的这个技术呢，术式安全而且精准。那无论是对于初次接触植牙，或者是这个植体用量较大的贵宾，一定都相当的有帮助。那么紧接着下来呢，我们要告诉大家，我们要即将到我们的抽奖时间。那所有这个抽奖的贵宾，您一定要在现场哦，才可以来领取我们今天为大家特别准备的这个 One Day Plan 的套组。那么更难得的是，我还要提醒大家，今天搭配了我们的这个 coupon 的优惠券，真的出现了破天荒的优惠价格哦。刚才 Jennifer 也有到这个我们的外地看，真的是非常的优惠。也相信大家都已经发现，我们 One Day Plan 将在未来植牙市场上面有举足轻重的存在，所以一定要请大家把握这一次的大优惠，带几组回去感受一下我们 One Day Implant 的植牙技术所带来的便利性还有安全性。好，那么紧接着下来呢，我们要抽出20组的 One Day Implant 的套组的名组啊，都是市价3万元哦。那在这里呢，我们是不是先有请国际植牙的这个矫正植牙学会理事长张慧楠张理事长上台来为我们抽奖，好不好？热情的掌声给我们的张理事长，欢迎！我们要抽出来哦，总共有20组，那么请